Hi, I'm Shannon Brownlee. I'm Senior Vice President of the Lown Institute, and I want to welcome you to the second Lown Presents event, The Promise of Hospital Cooperation.
And I'm VIKAS, President of the Lown Institute. Today we have some fantastic guests. Paul Levy, former CEO of the Beth Israel Deaconess Hospital here in Boston. David SELTZ, who's Executive Director of the Massachusetts Health Policy Commission. And Jill HORWITZ, who's Professor of Law and Medicine at UCLA. Let's get started. Whether we're individuals or organizations, our responses in times of crisis really define who we are. And never has that been more true, I think, than during natural disasters like COVID. This pandemic has shown us real heroism. It's been there on the part of people working in hospitals. They've cared for patients day in and day out. They've faced grave risks to their own health. Hospital administrators have docked their own pay to avoid letting employees go. And yet at the same time, hospitals have had very different burdens in terms of the numbers of patients they had to care for, how sick those patients were. And they've not always cooperated on their own until and unless they've been encouraged or even mandated. So in Massachusetts, for example, at the urging of the state government, our hospitals took patients when needed, shared masks, other supplies, and had regular communications. But in California, we've read in the press that some hospitals were overflowing with patients, and other hospitals had more than 100 empty beds, and yet some of them refused or delayed to take care of those patients, not accepting them for transfer primarily because of their insurance status.
And New York City was a prime example of how this failure to coordinate hospitals threw the disparities into very sharp relief over who gets COVID and who dies. In neighborhoods like Queens, where much of the population is poor, Black, and Latinx, these are the very people who are most likely to get COVID and die from it. Hospitals had insufficient PPE, too few beds, and a flood of patients coming through the door. But hospitals in Manhattan, just over the bridge, were not even close to capacity. At the time, New York Governor Andrew Cuomo said, "We are one health system," and he called COVID the great equalizer. Doctors on the front lines knew better. Dr. Alan Roth, who's a chair of family medicine at Jamaica Hospital in Queens, said his staff was completely overwhelmed with COVID patients. They didn't have the equipment they needed. They didn't have the drugs they needed. They begged for help and no help came.
The Lown Institute Hospitals Index shows that this pattern, with some hospitals caring for many more low-income patients than others, that didn't just start with the pandemic. The Lown Index is the first hospital ranking to include metrics of civic leadership. One of these is a metric we call inclusivity, which measures the extent to which the patients inside the hospital match people who live in the surrounding community in terms of income, race, and education. We found that many of the hospitals hit hardest by COVID have very high inclusivity scores on the index, which means that they're serving more than their fair share of people of low income or from communities of color. In comparison, some of the wealthy hospitals that still had beds open during the COVID period, the surge in last spring, were carrying far fewer patients from underserved communities. The difference is especially stark in cities like Los Angeles and New York City. The slide shows a comparison of Alan Roth's hospital in Queens. They were in the 79th percentile of inclusivity. New York Presbyterian Hospital across the river in Manhattan was in the 3rd percentile. So there's a similar comparison in other cities. So the comparison with MLK shows that it's a safety net hospital in Los Angeles. Cedars-Sinai is a well-known academic medical center. And in the first COVID wave, Cedars-Sinai allegedly declined transfers of COVID patients because they were uninsured or on Medicaid, even though the hospital had 120 ICU beds available.
So the bottom line is that COVID has shown us in no uncertain terms what happens when we don't have a coordinated system of hospital care. People die, healthcare professionals are overwhelmed, and the harm from this dysfunction falls hardest on communities of color. And while some are calling COVID a once-in-a-century event, other experts are saying that global warming and mass human migration means more frequent pandemics. So for the sake of future patients, shouldn't we be thinking now about a system in which the hospitals in a city or a community or a region actually work together in future emergencies? And what might be possible in non-pandemic times if hospitals worked as part of an actual health system? In this episode of Lown Presents, we and our guests are going to explore what it means for hospitals to cooperate within a truly coordinated health system and what it's going to take to get there.
Let's start by introducing our guests. Paul Levy is an author, speaker, corporate advisor who served as president and CEO of the Beth Israel Deaconess Medical Center in Boston from 2002 to 2011. He was the author of a widely read blog, Not Running a Hospital, and he was one of the very few hospital CEOs who shared his thoughts publicly about the business side of hospitals, medicine, and healthcare.
Jill HORWITZ is Vice Dean for Faculty and Intellectual Life at UCLA. David Sanders, Professor in Law and Medicine at the UCLA School of Law, and Professor of Public Affairs at the UCLA Luskin School of Public Affairs. She's both a legal scholar and a policy expert, and she addresses some of the most pressing law and policy issues of our day, including the opioid crisis, health insurance, and healthcare markets.
And last but not least, David SELTZ is the first executive director of the Massachusetts Health Policy Commission. The HPC is an independent state body charged with bending the healthcare cost curve and providing data-driven policy recommendations regarding healthcare delivery and payment system reform. During the pandemic, the HPC has been working closely with Massachusetts government and the hospitals on hospital coordination and capacity planning.
So we're going to kick this off by talking a bit about the status quo when it comes to hospitals working together. Paul, as a former hospital CEO, can you paint us a picture of how hospitals operate within a particular region or a city, or should I say a particular marketplace?
I'd be delighted. And also thank you for having me. And it's great to be here with Jill and David as well. I think the picture I'd like to give you is of a solar system. If we think of a metropolitan area with a number of hospitals, there are all these independent planets going around the sun, slightly perturbed in their orbits by what's going on in the other hospitals, but pretty much independent bodies with their own momentum and inertia. If we think about the larger facilities in Boston, it tends to be academic medical centers. In other communities, it's not necessarily academic medical centers, but good-sized general hospitals. And think about what motivates them in their day-to-day business operations and in their decisions about how to specialize and what to emphasize. They're clearly, it's appropriate to think of them as corporate entities more than anything else, unfortunately, driven by the bottom line. In one level, but they're also entities full of doctors who have their own particular interests and career objectives that are very important to consider when you're the head of one of those hospitals. So what is each hospital trying to do? In a business sense, they're trying to have enough of a feeder system to bring in patients from the communities, either directly from primary care doctors or other doctors, or from secondary hospitals in the communities. And these large institutions survive in great measure under the reimbursement system or the payment system that now exists by doing the more complex procedures and handling the complex diseases. So cancer care, heart surgery, vascular surgery, and the like. In addition, the people who tend to go to work in those hospitals, particularly the academic medical centers, are people who are super specialists in their areas of endeavor. Liver transplant surgeons would be an example. And they are viewed as very important people in that environment. And hospital administrators often feel that they have to take steps to enhance the reputation and the well-being of those individuals. The result of all this, if we think of a metropolitan area and its actual need for service lines, is that we tend to overbuild and create too many programs doing the same things in a metropolitan area. So for example, if we look at the field of liver transplants in Massachusetts and New England, I forget how many liver transplant programs there are. I think it's something like 10, David, or something like that. Whereas we probably only need 1 or 2, given the number of livers that exist, but everybody that are available for transplants, but everybody wants to have a liver program. We've also seen this in other metropolitan areas with construction of proton beam radiation machines, which
My favorite example.
my favorite example. And originally, we envisioned having 3 or 4 of those in the entire country, and now we have in some cities we have them within 10 miles of each other. A total waste of resources. But people view if you're the CEO of a hospital and you're looking at your finances and the future, and whether you want to fight a battle with your senior doctors on this or that, it's just not worth your effort to do that. In addition, the bigger hospitals are always interested in engendering philanthropy, and very often you have wealthy donors who are grateful patients who have particular interests in pursuing one or another specialty. And sometimes you'll end up building out a program even though it doesn't make economic sense, directly because of what it means in terms of your philanthropic relations. So I think the point, VIKAS, of what you were saying before, and Shannon, what you were saying before is we're not actually defined by what happens in a crisis. We've been defined by what happens in the day-to-day. And the day-to-day is not a very pretty picture. Go ahead.
So I have a quick question. So if there are too many car dealerships in a city and everybody's already got 5 cars, then somebody goes out of business or moves to a different city or something. Why doesn't that happen in the hospital sector when there's oversupply?
Well, for one thing, because there's no imperative from the payers to make that happen. In the car business, we have individual people who buy cars. And if not enough of them show up, then the business goes out of business. In the hospital world, you get paid by the insurance companies and by CMS and by Medicaid, regardless of whether we actually need you in a societal sense. The need is demonstrated by the fact that you have 1 or 2 or 10 or 100 patients as far as they are concerned. So we don't have the same impetus from the payers. Now there have been some examples, and I think we'll get into this a little bit later, where as a result of state action, either formal or informal, and as a result of some pressure from insurers, there have been some limits put on certain programs. So for example, when bariatric surgery was starting out, the insurance companies in Massachusetts, Blue Cross in particular, realized that to properly offer bariatric surgery, you can't just provide surgery, you have to provide all kinds of counseling and dietary support and all that. And it's a big investment, and they wanted to make sure that money spent on bariatric surgery would actually be well spent. And so they established criteria for which hospitals would be allowed to do it. Likewise, we did that for heart transplants early on. But over time, those limitations have tended to be relaxed. And I think a question we might want to talk about later is why?
Uh-huh.
And
Interesting.
when, I would say, when did they start getting relaxed? My understanding is there was a wave of that kind of deregulation starting in the 80s through into the 90s.
But the bariatric was even later. This was in
Yeah.
the when I was at the hospital in the 2000s. When it first started out, it was that way, but within about a decade, it went away. So I think there's tremendous pressure on the government and the insurers to let us do everything we can do, because you never know, or whatever it is. I mean, we had a situation in Boston where Boston Medical Center had a kidney transplant program. And at the time when I was running BIDMC, I think they might do 10 or 12 kidney transplants a year. Well, anybody can tell you that surgeons who are only doing 10 or 12 transplants per year, let's just say, are likely to have poorer results than surgeons who do more than that. But they felt that they had to offer that program. Likewise, when I was at the hospital, Dartmouth decided they wanted to start a liver transplant program, even though there were already 9 other programs in New England. And why? There was just no commercial basis for it. But the faculty up there really, really wanted to do it, and the administration didn't want to get in their way. So there's some psychology here as well as business. So
there's a prestige part, but isn't there also, like, look, is anybody creating something that's a low margin procedure because they really want to, and even though they'll lose money on it?
Those don't seem to move very far along, do they?
Yeah. So there's this combination of, there's sort of the prestige factor, and then there's the high margin factor, and the confluence of the two means you got a whole lot of proton beam and you got a whole lot of transplant.
Well, let me add something to that. It just comes to mind with regard
and
to
everybody
BMC,
else too.
With regard to BMC, for example, there's also a question of what community do they serve, and do they feel like their community will be served if they don't step in? So there are some really complex considerations. I certainly, completely would, endorse, most of what you've said, Paul. But Shannon, I think the underlying premise of your question was that if there's oversupply, somebody might go out of business. That assumes a supply-demand curve on pricing.
Yeah, and it actually works as a market.
Yeah, and it assumes that if that actually worked, then people would go out of business. The reality is quite the opposite.
That's right. Now, one thing I will say on the positive side is when really bad things happen, short-run bad things happen, like when there was the marathon bombing in Boston a few years ago. Boy, at that point, you saw tremendous cooperation across the city in the emergency departments and elsewhere. And so underlying all this, I don't think we should forget that the people running these institutions and the doctors and the nurses are very well-intentioned people. I mean, they've devoted their lives to helping the public. And when a crisis emerges, usually they respond. I think in the case of COVID also, at least in the Boston area, you've given some counterexamples, but I think in the Boston area, there's been pretty good cooperation on that front. And in part, I attribute that to the leadership of our governor, Governor Baker, who very early brought in the hospital leaders and the other medical leaders and said, okay, now's the time to work together. And I think everybody stood behind him on that.
David, I think we'll hear from you a little bit more on those details, but Jill
and David, jump in here and yeah, does what Paul has been talking about ring true for your perception of sort of the hospital landscape?
It does, absolutely. I mean, I think a couple of quick reactions, on the car dealership metaphor. I guess I still worry that there, not to stretch that metaphor too far, but that there are car dealerships in certain neighborhoods and communities that are at risk of going under. And what does that mean for the, to stretch that metaphor, the transportation needs of those communities applied to the healthcare setting? absolutely large academic medical centers are always in a position of perhaps greater financial strength and the leverage to negotiate higher pricing. Not all hospitals have that opportunity or are situated, and many of the hospitals that do not have that leverage, do not have demonstrably higher pricing, are ones that treat a disproportionate amount of public payer patients, Medicaid patients, and Medicare patients, and in communities of sometimes greater healthcare needs. So there is multiple market dynamics there that ultimately I do think have resulted in a fragile healthcare system that has not always worked well together to meet the true healthcare needs of this state prior to this pandemic. And, I'll speak more about it a little bit later, but I think it has, over this past year, really shaken some of the silos, broken silos down, broken ways of what would have been competitors to actually think about how can we collaborate, communicate, and coordinate our resources, our staff, our everything from PPE to ventilators to critical care nursing staff around a region or around the state to meet the COVID needs of the patients of the Commonwealth. And to me, it's been an absolutely remarkable achievement. Not perfect, of course, as we know from the disparities in outcomes for people and communities of color. But I think something worth exploring how we might be able to sustain the successes and the lessons learned into the future, and what policies and structures need to be put in place to incentivize and reward that type of collaboration, not competition, moving forward.
We're going to ask you that very question, because, sorry.
Yeah. So, in terms of the car dealer metaphor, there's another one that I like a lot better because I think it underscores the difficulty of thinking about healthcare like a regular commodity. And that is, would we ever, with public support, fund two airports across the street from each other? I mean, do we really do that? I mean, are we that insane? Well, not for airports, but apparently for healthcare, that's kind of the system as it's evolved. So Jill, I want to ask you, from your perspective, does the competition that is part of the healthcare landscape, what kind of role is that playing? Are there good qualities to it? What are the elements of it from your point of view?
So I'm sitting here listening to this conversation, which is fascinating. So thank you for inviting me. And I've been thinking a lot of things. It's hard to know where to start. I guess, I will start first by telling you something personal. I grew up in Boston. I spent most of my adult life in Boston, but I've lived in Chicago, Los Angeles. I was on the Michigan faculty for many years. And one of the things I learned is that people don't walk across streets or drive like they're in Boston. I almost got myself killed several times, but when I tried to cross the street when I first went to university in Chicago, because people watch for the crosswalk to be open. But the systems are really different than outside of Boston. The geography is different. Managing a hospital system in California with 30 million people is really different than the hub and spoke Boston system. And because so much research and such competent healthcare regulators exist in Boston, including the governor, we tend to generalize from what happens in a very sophisticated and integrated system, integrated relative to other places. So I think we can learn lessons from what happens with the, big Boston systems and the suburbs, but we have to be careful not to generalize too much. There are several ways in which we generalize, which I think makes us make some mistakes about the assumptions about how hospitals work. So one of them is that we tend to see nonprofit hospitals as the big academic medical centers that are very financially sound and savvy. But when you look across the country, the average nonprofit medical hospital or acute care hospital operates in the red in a given year, right? We tend to think about the big guys and how much they have in fund balances and how many donations they have. That is not how the ordinary nonprofit hospital works. So I think we need to be careful about generalizing. And what that also teaches us is that these hospitals need to find a way to get revenues. You know, there is no money tree here. And so if we're not careful and we set up incentives that allow them to over-provide very profitable care, that's exactly what we're going to see them doing. And so we need, I think, a competent at least government partner in competition. So let me give you one small example, something that I've written about, but I noticed and started researching because I used to live very close to the Ohio border when I lived in Michigan. Michigan has a certificate of need program. In my view, a lot of it, you know, there's some co-opting of the system by the big institutions, as there is everywhere, but more or less, I think it worked. But Michigan borders Ohio, and the big systems are very close to the Ohio border. And so I talked to some of my doctor neighbors, and what they used to do for diagnostic imaging was send them across the border to Ohio to get CT scans and MRIs. And so even though Michigan was fairly successful in being efficient with its use of diagnostic imaging and keeping billings down and keeping those scans in relatively safe places, the spillover right into Ohio meant that people would cross the border. So in fact, I went to go visit a friend in Cincinnati once, drove across the border with my family, and this is the problem of being in a family with someone who's a health economist, is I made them pull over as soon as we got across the border and chart where the freestanding CT scans were. And they were available in strip malls in the middle of nowhere, all just across the Ohio border from Michigan. And so I repeated this exercise in a big empirical study and found, lo and behold, the states that were unregulated right across from the regulated states had much higher rates of diagnostic imaging, including CT, which comes, you know, with a radiation load. And so there's some real safety concerns there. So on the one hand, we need to be cognizant of what's happening within these markets, and we need to have government involved, but there's an important federalism lesson here. For cooperation and for incentive setting.
So we have to define the effectively the market for healthcare, not bounded by county borders or state borders, but really by where is it that people are able to get their care.
So someone just asked, right, how doctors or patients in Michigan benefited from sending their, they get cheaper scans because, you know, Michigan had a monopoly, right? You know, the question, Michigan was probably, the university was probably charging higher prices because they had some kind of anti-competitive power, even though probably socially that was the right answer, a slightly higher price for the individual scans, but many fewer scans overall. And they get them faster, or their patients would go during the day instead of, you know, at an inconvenient time because the University of Michigan system was running those machines all night.
Yeah.
So do a quick definition of certificate of need for anybody in the audience who doesn't know what that means, what it is.
There's state programs that require healthcare providers to get permission before opening either a new service line, sometimes a whole hospital, sometimes buying a new machine. Sometimes the state says you can't buy a new MRI unless you show us that you've got adequate demand for it. Sometimes those laws will be triggered by expenditures. So you need to get a particular license before you can spend over, you know, $20 million, something like that. And
see, one of the questions, Jill, one of the questions I'd love to toss your way is what role does this differential pricing, you know, between different insurance plans and the fact that what, the margins vary with your insurance coverage as well as which procedure it is. To what extent does that actually drive some of this? And to that extent, you have to look at the payment side as well, I think, right?
I think it drives a lot of it, but again, I think it varies by the type of hospital. So, for example, much of my early research was on differences between nonprofit and for-profit hospitals. And if you look at every hospital in the country, we did it over 20, 25 years. There are really striking regularities in the provision of blunt categories of services. So the for-profits are much more likely to offer the very profitable services, and the nonprofits are much more likely to offer the less profitable services. So I think that's, you can see it cash out even in, do you have psych emergency? Do you have invasive cardiac procedures? Do you, when do you open SNF units in response to financial incentives to do so? And huge differences between nonprofits and for-profits in that respect. And so what I worry about is when nonprofits are increasingly asked to provide unprofitable services, they've got to raise that money somewhere. And I think the way to do it is just offer more services, right? More profitable services. And I think that's one of the reasons why we see the over provision of invasive cardiac services, for example. It's because the money has to come from somewhere.
Yeah,
exactly.
And it used to be at one point, interventional cardiac services were the only profitable service line for some hospitals. And it was a pretty hefty profit margin. So we're going to move on a bit to a question that's I've been wanting to know more about. And David, we just want to spend a little bit of time about what happened in Massachusetts, specifically during COVID. And I'd like everybody to kind of jump in on this once David's kind of set up what the landscape looked like and what was different during COVID.
Yeah, great. Thank you so much. And actually, I just want to quickly respond to something that Jill said, and then I'll pivot quickly to the COVID adaptation. I think Massachusetts actually is a really unique state and a model because we have at the Health Policy Commission a role and responsibility in tracking, monitoring, and evaluating how changes in the healthcare market and the organization of how healthcare is delivered impacts cost, quality, and access for the residents of the Commonwealth. And we conducted, along with the Department of Health and the Attorney General's office, a very significant review of the Beth Israel Leahy merger recently, and noted in our review that the new combined system, which would be the number 2 system, served a pretty low proportion of non-white patients and non-commercially insured patients. And by putting that information publicly and having a discussion about what does this mean for a balanced healthcare system, that transaction was allowed to move forward, but with some very clear restrictions and approvals and strings attached that can provide, I think, a model for how government can help steer the marketplace to provide better value in how it's organizing and better equity in how they are thinking about different patients and different populations and the services they provide. So just a quick note about how Massachusetts is thinking about that balance between market-based incentives and government-based incentives. I think to pivot to the COVID conversation, I too want to start and acknowledge at the top that anytime we talk about COVID, I think it's important to recognize that thousands of people's lives were lost here in Massachusetts. Thousands more were hospitalized. This is an impact that will be with us forever. Certainly for those who lost loved ones or friends and neighbors, but also in terms of the long-term health impacts of COVID and of course the economic and financial impacts will be with us for a long time. So I always want to center in the human element of this and also give a real recognition and credit to our unequaled Secretary of Health and Human Services, Mary Lou Sutters, and the command center here in Massachusetts, who made it a central principle of the state's reaction to minimize that human cost as much as possible in thinking about the way that the state was going to approach the response to this devastating pandemic. And I think there have been, we've talked a little bit about how market incentives and competition may not have contributed to a right sizing of our healthcare system to meet this challenge. And on top of that, hospitals and staff were under-equipped and overwhelmed at the beginning of the spring surge. And as I said before, I think have just really done a remarkable job in adapting, evolving, learning from successes and failures, and really starting to work together as a healthcare system. And that required organizations to be creative. There's a quote in Governor Baker's State of the State last night: "If there is a silver lining in all of this, it's how organizations and individuals from every corner of Massachusetts stepped up to confront the pandemic and care for each other. These heroes are the most beautiful part of this difficult experience." And I think the response of the healthcare system, including hospitals, is perhaps an example of this silver lining. And I'd love to give just a few examples of how I've observed that this has played out. But first, do want to acknowledge, as Paul, I think, said, hospitals are complicated organizations, and they're oftentimes organized into even more complicated health systems and have a lot of internal and external interests and priorities, variation in who they serve. Jill, there is no generalizations here when talking about hospitals. And they're made up of people, people who are frontline workers, who are administrators, who are leadership, who are all working together to achieve the vision and mission of that organization. And really it's through their actions and sacrifices that we've been able to weather this and provide still world-class care to so many patients. And I don't think that the clinical, operational, and financial challenges posed by the pandemic on hospitals and the healthcare system can be overstated. And so what has been the reaction? And I think as a first example, there were creative adjustments that needed to be made within hospitals, thinking about the priorities even within a hospital. So for example, understanding the need that we had to quickly free up capacity within our healthcare system. In the spring, non-emergency elective procedures and services were essentially halted and delayed. And you can think about this, the implications of this are really multifaceted for hospitals, as these often provide important revenue to maintain the financial stability. And yet at the same time, the need was really in building capacity. And so hospitals internally had to reprioritize and take the creative steps to redeploy and retrain staff, redesign the physical space that may have been set aside for some of these high margin scheduled procedures into essentially what was needed, which was in the spring, ICU beds and intensive care beds. And I think you can take that same breaking down of priorities and silos outside of the hospital and into health systems. We have many multi-hospital health systems in Massachusetts, and they really had to work together as a health system, not as a corporate entity that's really only connected to negotiate contracts, but as a healthcare institution that was working within these systems to balance patient needs, balance patient capacity, manage PPE, other supplies, and sharing clinical strategies, quality improvement strategies in absolute real time in a crisis. And I think there has just been tremendous progress and innovation, even within a multi-hospital system. And then going beyond the hospitals, hospitals really had to think more about their connectiveness with the whole care continuum. And this is an appreciation that I truly have gained through this experience, is how interconnected every single part of the healthcare system is when you're facing extreme capacity constraints or a system that maybe isn't right sized to meet the challenge. If hospitals can't discharge their patients to skilled nursing facilities or rehab hospitals, they'll end up being stuck in the hospital. That's a bed that couldn't be used for someone who's stuck in the ER. And you can think of all the way through the care continuum, how everything has to be moving efficiently, and that pieces of the healthcare system that we think and that we hope would be talking and sharing, really had to do so in a much different way. And of course, I think of not just the healthcare system and skilled nursing facilities and nursing homes in particular, but also the prisons and homeless shelters. And now with the vaccines distribution, how are our healthcare systems actually connected to our public health infrastructure in ways that are really, equal and delivering on the mission that needs to happen. And I think to kind of put a bow on this, all of these lessons learned throughout the spring and through the summer when we were in a reopen stage, when we thought about, when the state thought about, and when the resurgence planning for this fall, there was a real emphasis on collaboration among hospitals, even those that aren't part of your same corporate structure or aren't part of your multi-hospital health system. And so the structure that the state put in place for the resurgence in the fall was one of regional collaboration, where hospitals would meet very regularly to discuss their patient needs and to work together to transfer those patients, even if they're not part of the same system, even from a community hospital to an AMC or vice versa, so that the patients are getting the best care in the best setting possible for them, and that we can share, and that hospitals across a region could share the burden, so that no one community or one hospital is really disproportionately bearing that. And that's been the approach throughout this fall and winter. And I think the most salient example of this working is through the specialized COVID unit at the DCU Center in Worcester, where that specialty unit has been able to accept patients from literally all over the Commonwealth and provide excellent care. And hospitals have been willing to work with that center to transfer their patients from Lawrence, from Boston, from Fall River, to Worcester to receive that type of care. So I think there's just so many examples along the way of these types of new ways of working together and communicating with each other. I think the question that I raised earlier, and the question I think for our time is how do we take some of those best lessons learned? How do we sustain them? How do we think about our workforce and retraining our workforce? How do we think about our resources? And happy to note and excited to begin this work is that in a recent healthcare bill passed by the legislature, they've actually tasked the Health Policy Commission with doing a directory and inventory of all healthcare resources in the Commonwealth, and really evaluating whether they are right-sized and in the right locations, and to meet the needs of all patients in an equitable and fair way. And so really thinking about how do we redesign or improve our delivery of our healthcare system for not just the challenges that were there before COVID, but of course for the new challenges that we know to come.
Thanks, David. So I think, what you've described is, an excellent summary of, a situation in which, when the moral imperative is there, when the political leadership is there, and in that context, a certain amount of coordination is there, that we can integrate and delivery systems and rise to the challenge. But this is a specific challenge. This is a specific virus with a specific clinical profile, respiratory, et cetera.
And a limited time.
And
horizon.
so, generating that across the entire healthcare system is, I think, a bigger challenge. And the other part to this is really that in that limited time period, the hit to finances or the pause on high margin activities and procedures may be, and especially with government aid, may be possible or tolerated. But when we're back to business as usual, it's really an important and big question. How do we actually manage this? So I want to turn really to that question, which is, what if we did this on a long-term basis? What if all our hospitals in regions of the country actually acted like an integrated delivery system? Is there any kind of a model for that? You know, is there any such institution now that sort of even starts to get there? Is the VA an example, or is Kaiser an example? Jill, you're currently in Canada, so I wonder, you know, what capacity kinds of measures are done in Canada as well, because I think if we're gonna grasp this and move it forward, we have to talk about those items as well.
Yeah, I mean, that's an enormous question.
Yeah, isn't it?
So, you know, I would say a lot of the ways in which cooperation and responsiveness, it's both of those things together that have happened. The reduction of regulatory hurdles to being responsive has been an important part of what's going on. So the promise of reduced or eliminating antitrust enforcement during this for certain kinds of cooperation has been really important. The relaxation of bed licensing has been important. Telemedicine permissions and fee increases, the release of scope of practice rules, all of that has allowed for responsiveness at this really key moment. But a lot of that, if continued, would allow some big players to get bigger. And you know, when we have giants in a field or in a market, that means that care gets more expensive. That's sort of irregularity you know, that we can't make disappear.
Because they have pricing, they have the ability to demand prices of private insurers.
Yes, and that has spillover effects to other hospitals in the area. So I really worry about that a great deal. I mean, I think there's, you know, one lesson that's we didn't need this crisis to learn, but it's showing us yet again that access to care for poor patients is not a difficult policy problem. It's a difficult political problem. So, you know, how do you get people access to care? You make sure that they're covered at the same rates as other people, you know, with private insurance, and you pay those rates, you know, whether you're lowering the rates of privately insured or raising the rates of people who are publicly insured. That solves your problem, right? That's a political will issue. That is not something that you need a lot of enormous brains to figure out how to do. But all these other things that we're talking about don't disappear in a single payer system. I've seen virtually all of it happening in Canada. There's competition among, you know, health regions. There's the problem of getting the population here does a better job listening to experts, and they haven't had experts undermined to the degree that we've had experts undermined in the States. But all of these issues of where the resources flow, how people get into the system, you know, how you strike the right balance and the right amount of pay so that you can get an adequate amount and quality of care are all issues that have to be sorted out. And they're difficult policy issues that exist even in a single payer system.
Mm-hmm. So Paul, I'm a concrete thinker. And I like having examples of things that work as a way of thinking about how to get to something better. Are there systems in the United States then that really do this kind of right sizing that we're talking about, that really do this cooperation among their various hospitals, et cetera, et cetera?
Well, let me get back to that in just a second, but
okay,
if I may, I think David gave a wonderful explanation of what happened here, and I agree with him that it worked remarkably well, especially given the exigencies of the time. And then the cynic or the skeptic in me says, but wouldn't we expect that? I mean, in the worst environment in a century, that the brain power and the political will if it hadn't delivered what he suggests, did happen, and we give credit to that, that would have been a real indictment. The earlier examples you gave from New York and elsewhere indicate that that didn't happen everywhere.
Yep.
In terms of future emergency planning and crises, it would be interesting to maybe for Jill's graduate student to somewhere to study what made it happen here versus other places. The other thing is, to get back to VIKAS's point, once that's gone, things will simply revert.
Yep.
As one of our commenters has said on the chat room, we already see billions of dollars in expansion of facilities by the most powerful health systems in the Boston metropolitan area. David's organization simply was not given enough authority by the legislature to preclude that from happening. The legislature and the governor at the time did not want to change that environment as a result of the political pressure from the market dominant leaders in this area. Martin Gaynor at Carnegie Mellon has done a lot of work on market power, and as Jill suggests, when you have market concentration, you have higher prices. I mean, it's like a one-for-one correspondence. There is no doubt that. So the other side of your question, Shannon, is let's take a look at the places that might be doing it better in terms of coordination. I can think of Geisinger in Pennsylvania. I can think of Kaiser Permanente. Interestingly, those are integrated not only health systems, but insurance companies as well. So they have the ability to do transfer pricing internally and maximize over two lines of business, both insurance and healthcare. And again, boy, if they can't do a good job, who can? And so, but the question is they're dominant in their areas in terms of customer choice and the like. And there is a decided trade-off. Now, I have seen some systems around the United States, and they've tended to be in the Midwest United States, where there seems to be more of a communitarian view of the world. I don't know if we were to stereotype, maybe it's because the Scandinavians settled those parts of the country when the Europeans took over from the local folks. But if you look at the Gunderson Lutheran system, for example, in La Crosse, Wisconsin, boy, particularly under the leadership of Jeff Thompson when he was the CEO, you saw community engagement in a big way. Integrating public health issues, diet, even so far as to integrate energy sustainability planning into the hospital's function, because as Jeff used to say, boy, every kilowatt hour we use in our hospital is created by a fossil burning plant that's causing our people to be less well. So they've taken the broad view. I've not seen so much of that in the great academic centers of the East and West Coast, or even in Chicago. Further, I don't see where the impetus is to make it happen.
Yeah.
Underlying this all, I don't see a political constituency to talk about the kind of long-lasting integration of public health issues and rationalizing care across the system. I just don't see where the constituency is for that.
So let's talk about that. Let's talk about how we get from here to there in a number of ways. So, David, I'll let you go first on this one, but Jill, you made the point that, single payer by itself doesn't address some of these issues. And yet I would want to at least acknowledge that, the buying power, the single purchaser power, would almost certainly have a significant effect. I think maybe less than many proponents imagine, but it would have an effect. And so I think it ought to be in the mix of solutions, but I don't think it's sufficient. So the question is, let's say price discrimination weren't there. Let's imagine either a single payer system or some system in which compensation was the same across the board. What other changes do we need to see in order to essentially create the incentives for the kind of integrated care that we're discussing? And then this part two to this question, really, which is a big one also, but I want to respond to something in chat because I think it's a real issue, which is what we've learned in COVID is there's a need for coordination. Some of that is due to surge issues. And when we get back to business as usual, presumably those won't exist. And yet the coordination and integration that we hope to see and achieve would still have merit on their own grounds. But how would we decide what's the right size? How do we determine that? Is that a technocratic question or is that a political question or some hybrid of the two? David?
Okay, a lot there. I'll start with the first question around what else do we need, thinking about if payment discrimination were eliminated. And the example that I was actually going to raise to Shannon's question is the model of Maryland, where they have a hospital global budget system that is run by the state. Payment rates are set, Medicare, commercial, and Medicaid all pay the same. And the financial structure beyond that, though, is one in which the hospitals are understand what their annual budget is, and to the extent that they're able to create efficiencies, they gain those revenues back. And so this type of global budgeting, I think, is critical to thinking about, to Paul's point, how do you marry the financial incentives with the care delivery system that you're trying to achieve? And interestingly, in the Maryland example, those hospitals were actually in a much stronger position vis-a-vis other hospitals in the United States, because as they lost all of their elective revenue, that wasn't necessarily a hit to their bottom line, because they had been provided that stability and predictability of a global budget. And that changes the incentives away from overutilization, over acuity, and actually creates incentives to provide the best care, perhaps not in the hospital setting. And so I do think, and that can be, and we've seen that there have been global budget type financial arrangements that have occurred outside of a government run program. Those have existed in private health insurance companies as well. So I think it's not just about what the payment rate is, but how is that payment structured in order to really provide those types of financial incentives. I think to take a little bit of a different spin on your second question around kind of like what is, I don't know how many beds we quote unquote need, for the future. I think that will be an examination that many states and we ourselves will look at. But I guess I would just kind of pivot the question to say, to challenge this idea that, hospitals came together because of this crisis with COVID, and that can, once COVID goes away, then, it's going to be back to business as usual. I think that is absolutely a huge concern, unless there is coordinated action to say, hey, guess what, healthcare system? COVID was an incredible crisis. You know what else is an incredible crisis? The impact of systemic racism on our healthcare system and what that means in terms of health equity and disparities. What if we attacked health equity in the same way that we attacked COVID from a healthcare system and coordination standpoint? And how do you create that type of environment to say, we have so many crises in healthcare? And what are the types of incentives and structures, political and otherwise, to get people to work together on that next big crisis? And that may not be building more beds. That may be around how do we actually connect healthcare with housing, with food security, with transportation, with behavioral healthcare and other social needs in ways that we have not been able to as a country yet to date.
So I'm dying to hear two things, one from Paul and one from Jill. Paul, I want you to talk about what it would be like to run a hospital with an actual real global budget. You know how much money you have for the next year. You know what your patient population is, sort of. What would that be like? And then Jill, I would love you to talk about sort of some of the what are the steps that would be needed to get to a Maryland model for other states? Because the Maryland model has been around for 40 or 50 years, the all-payer rate base, and so they're all used to it. So could we kind of push that for other states as well? But Paul, what would it be like to have a global budget? Would you have welcomed that, or would you have,
we would have dealt with it. We would have figured out a way. But really, no one is proposing a global budget. Nobody, there's no realistic expectation of a global budget. There might be bundled pricing for certain clinical enterprises like heart surgery and so on. But there's not been a great impetus for global pricing, even in single payer environments, like in Canada, they don't do that.
But Paul, the question,
and there's a reason they don't do that. And the reason they don't do that is because in great measure, the doctors, the primary care people in the hospitals really don't want that. I mean, think about, imagine the hypothetical negotiation you would have as a hospital administrator trying to talk to everybody from the primary care doctors and the neurologists to the heart surgeons, deciding how the hospital's global budget should be allocated among those services. Think about how you would try to explain it to everybody and how you would design that process in a way that would not have unintended consequences. David before talked about the advantage of a global budget of not over-treating people, but there is a tendency to undertreat people in that in order to generate the surplus that you get to keep at the end, in addition. So but I have to say, I think, with all due respect, even thinking about the possibility of that is probably not a useful exercise. There are other more important things that have to take place well before that are much more likely to happen.
Well, Kaiser
Paul,
Hospitals.
my question really is about what you just said, whether or not you're saying this is impractical given the realities of the players and the system and the power, or whether this is actually a bad idea technically.
Well, I don't see how you separate the two. So Shannon was asking me how I would deal with it as a hospital administrator. So you call in the doctors and you say, hey, heart surgeons, we want you to do fewer procedures because that will help generate a surplus for the hospital out of the global budget. And the heart surgeons say, okay, what are you going to pay me not to do a surgery?
Well, you'd have to pay them a salary. That's part of the, I mean, I think that it has to be part of the deal, because as long as their fee for service in the hospital is globally budgeted, there's going to be, friction.
Well, and
that's what Maryland's finding out.
Well, and in many hospitals, the doctors are not even employees of the hospital. They have a separate organization.
Right.
So I guess I'm just a practical kind of person. I'm sitting here saying I could struggle with that kind of negotiation. I don't know where it leads, because all of the primary players in it would view it as a zero-sum game, that if I somehow cooperate in this, I'm gonna lose. Meanwhile, the primary care doctors are going to say, gee, you need to pay me a lot more in order to spend time with those patients so that I don't refer them.
You can keep them out of the hospital.
Right. Exactly. And I'm all for that. I've always thought primary care doctors and other cognitive specialists should get paid more. Yeah. We can even get the Medicare payment rates adjusted to do that. Yet, not even short of global budgets. So. It's an interesting exercise to think about, but there's probably a reason why it isn't adopted in most of the world.
I would just add on the primary care side of this, we did a survey of primary care physicians in the late summer, early fall about their perspectives on their financial situation and on policies that they would like to see happen. And we noticed a pretty marked increase in receptiveness to at least partial capitation type payment arrangements among the physicians that we surveyed. I think reflecting a post-COVID world of, well, actually some predictability here, and getting off of the fee-for-service hamster wheel may be an advantage. And so I do wonder if there are opportunities, again, in a post-COVID world to rethink some of our perceptions of how payment can provide benefits to institutions as well.
And David,
So I want to,
the question I would ask is, who in the body politic has the incentive to push through those kinds of changes? The insurance companies clearly don't. They frankly could care less what it costs for the healthcare system because they get to keep their 15% of administrative and general as profit. They don't care.
they want it to get bigger, not smaller.
Right, exactly.
You know,
And
I think Paul's exactly right, and there's another level of problem there. So I would start by saying, you know, if we were all sitting down with everybody on this Zoom call to design a health system, when we design something that looks like the U.S. right now, and I mean, maybe if we were like on some kind, you know, dropping acid,
right.
you know, but
No, because we'd be nicer to people if we were.
yeah, maybe
dropping
we'd be
acid.
nicer, but like you know, we have the most ridiculous system you could, like, labor, you know, is where you get your health insurance. I mean, you know, over every part of this system is dysfunctional, but how you get from here to there is a completely separate question. And I think, you know, if it's even possible to think about global budgets, it would have to be done at the federal level, and that ain't happening. And why couldn't every state do it like Maryland does it? Maryland was able to thread a needle that I don't think gets thread again to overcome the ERISA problems. You just can't have that kind of system with the court system that we have now and have it not be rejected for an enormous part of the population that gets their insurance from big companies that self-insure and not violate ERISA. It's just not going to happen. So I think we need to think. We've got a lot of problems and a lot of people suffering, so we need to spend some time thinking about how we can do this realistically to improve what we have. And I think the one thing we can take from this time is find ways to have more states have the cooperation with the power of the AG's office behind it to do more organization. We have to encourage more Kaiser kind of integration. And that's going to be a hard swallow for a lot of Americans. They don't like it. I mean, Kaiser on a population level is magnificent. It's one of the few places we don't see stents placed in every 60-year-old white man, right? I'm exaggerating, but they're really good at things.
Not that much.
Yeah, not that much. And that's an expensive and dangerous thing that we do. But it's understandable given our incentives why that happens. But there are patients that don't like it and doctors that complain about it. And we have a very different population than in Canada. So, you know, there's griping up here, and there are doctor shortages where I live, despite it being one of the most beautiful places in the world. But you don't get in to see your primary care doctor very easily unless it's important. And the system isn't terribly coordinated until it gets serious. And then when you've got a serious problem, it's magnificent, you know, what I've seen happen. But that isn't how Americans suggest that they want to live. It's not the way they vote. And people in power would not put up with the not being able to get a primary care doc and having to go to a clinic. They just wouldn't. And so we need to take all the steps to get us there over the long term. So maybe the VA model is the right model, but we need the federal government just to force that through, and it's not happening.
And Jill, as you look around the world, the other thing that happens where there is a single payer plan, whether it's Israel or wherever, is or the UK, what emerges is a parallel private system that basically serves the wealthy or serves the investment bankers corporations that offer it as an extra benefit to their employees. And while you might have equity within the national system, there's certainly a major lack of equity between that and what's offered in the private system.
Well, what's interesting about the Canadian system is there's not much of it.
Right.
You know, there's a ton of exaggeration about it, and this idea that all these Canadians go across the border to get their care, and it
doesn't happen that much.
Yeah, well, there are a lot of Canadians that get their care in the U.S., and do you know where they get it? It's, you know, a little in Rochester. It's in Florida.
Yeah.
Those are snowbirds,
Yeah.
right? And there was a product that was put on the market in Canada, oh gosh, 25 years ago, where you could get insurance, line insurance, queue insurance. You could, the longer you stayed on your queue, you could go get your care across the border in the US, and it paid for your hotel and the whole thing. It went bust. Nobody wanted it. Right. So it's not that Canadians aren't happy with their system. They are happy with their system. And sometimes when you're old and in Florida, you get sick and you have to use the system elsewhere. But
the worst place in America to do that, of course.
Right, yeah. By the way, the oversupply is really, quite shocking. So I think the system that I would look at for insurance that I think might work for our population is something more like Germany.
Yeah. Or
But look, we have a comment from two people in the audience. One of them says, Donald Taylor, thank you, says, I've led both military and VA health systems where global budgeting helped optimize expenses while maximizing investment in health. The incentives of personal income were minimized. And I'm assuming he's talking about personal income of the clinicians.
Right.
And then Al Charbonneau says, global budgeting in Rochester allowed us to focus on our expenses because our revenues were guaranteed. It strengthened our ability to control expenses because there were community and business expectations. So, I recognize the worry about global budgeting leading to undertreatment, but I think patients and regulators are much better at detecting undertreatment than they are overtreatment, and B, kind of, worried about it, patients in particular. And so I think there's a sort of a natural push against, I'm not getting the care I need, I'm not being fairly treated.
Yeah, which is the way a lot of people at Kaiser Permanente feel, individuals.
Yeah.
Actually, what? I don't think that's true. I think that Kaiser actually has some of the most satisfied people in the system.
Yeah.
Well,
They stay in it for years. Their kids go into it.
On the VA,
Yeah. Look,
the people who join the VA system to work in the VA system have certain expectations about employment and the environment there, and they do a marvelous job. And I agree with that conclusion. I would love to learn more about the Rochester situation because I'm not familiar with that one.
I think the real story here is that the US is a big country and that, what works in Rochester may or may not work elsewhere. But the other part to this, that strikes me is that to me, at least, it's pretty clear that the financing has got to be national. Between the regional variation, between the inequality, the financing has to be national. And how you do that, and who's the constituency nationally to drive through not just the particular merits of a single purchaser, but who's going to drive through some of the global versus episodic, all of that. Politically, who's the constituency for that? That is completely, I think, a fundamental question.
Yeah.
Now,
really,
I happen to believe that, in a real sense, the constituency ought to be, the American people writ large, as rhetorical as that is, because I think as you look down the road and as you think about healthcare generally and the new technology and the pricing power we're seeing, without a countervailing force, and that countervailing force, I think, has to include some sense of there's a budget. We don't spend 100% of GDP on healthcare, but nobody can own that other than a broad constituency. And who's going to take that message to them is a big fat question. But that's for another time. I want to turn to a slightly different thing.
And if I may say, there's also a question of whether you need 51 votes or 67 votes.
Yeah, there is that problem.
Well, there is that.
We might actually be getting to the point where there's that you can get a federal response. As negative as I have been, when we were at 12% of GDP, you could just write it off as weird American taste, right? Some countries spend 12% of their GDP on, other goods. And so we just happen to like to consume healthcare. Who cares? What are you going to do with your disposable income anyway? I once heard an economist say, buy more Madonna videos. So that, dates me. But now when we're talking about 20% of GDP and how much the shift has gone to out-of-pocket costs, we're eating in not just to discretionary spending, but other basic human needs in a family. And so maybe, maybe in our lifetimes, we're going to see enough of a constituency that there will have to be federal movement on this. But in the meantime, a public option wouldn't be so bad.
Right. Well, that's the thing. I think that the question is, what steps could you take that are incrementally in the right direction?
Yes.
That could put pressure on the system to move in the ways we're talking about. Because it's probably easier to do that politically, and it may or may not be easier to do it federally, because versus in the laboratories of democracy in some of the states, you might not get as comprehensive a result.
I agree completely.
California couldn't even do it, right? California is really the only state, I think, that's big enough to be able to do it in a fully comprehensive way, and because of ERISA, it just can't fly. That needs to change, and then we could have,
the other point I want to make
I'd like to turn the conversation to one other topic before we close out. We all love to talk about, the big picture nationally, but this is directed more at you, Paul, but all the others as well. You have the experience at the level of hospitals and hospital leadership and hospital boards. Even at many nonprofits, the trend of the last 10, 20, 25 years has been real sort of corporate culture, sort of the MBA corporate culture. And my question is, how do we turn some of that tide? Which is, there's a chicken and egg here. Would global budgeting or some payment reform help? Or, what is needed in terms of leadership at the hospital level to do that, especially with younger clinicians, might I say?
So first of all, let's recognize that nonprofit is a tax classification and it's not a business plan. Whether it's a for-profit hospital or a nonprofit hospital, they're all seeking to make a profit or a margin. And underlying your question, Vikas, is the question of who governs those hospitals? What are the characteristics of the people who serve on the boards? And what are their expectations of the CEOs of the hospitals as established by those boards? Right now, the expectation is producing exactly what we have. Perhaps you're right that if we hopped over to a global budgeting system, that might change some of the behavior within the hospitals. In a direction that is more consistent with other public policy objectives. I would say, however, that we should recognize that the hospitals are separate corporate institutions from the rest of the healthcare system. They do not, even when there are global budgets, they do not engage in public health programs. And they do not engage in many, they don't engage in after acute care very often. They don't run the SNFs and the rehab centers and the like. So they will tend to think in a narrow way about the issue. But underlying it all, I think, is a severe problem in the governing structures of those organizations. We spent a lot of time, several of us in the business, to try to get hospital people to think about improving quality and safety in the hospitals, killing and maiming fewer people who were there for care. And surveys would be done of hospital administrators and boards saying, well, where on the continuum of priorities is quality and safety? And it generally showed up as number 6, 7, or 8 in the list, the first of which was financial results and market power.
I've seen multiple times now in the chat that we should refer to them as tax exempts and not nonprofits, and I could not disagree with that more. There's a huge difference between being a state licensed nonprofit and getting tax exemption, and those two don't have to go together, and they mean very different things. And the nonprofit state status is what gives the AG's office the power to oversee what goes on in the sector, including over hospitals. And in Massachusetts, that's a pretty effective thing. And so, as I said before, we don't want to get the ordinary nonprofit doesn't earn a profit in an ordinary year, right? They kind of hover around not making any profit at all. And we hear only about the biggies that actually make a lot of profits. I'm not so sure that's even a bad thing. When Paul was CEO, there was a big fund balance at the Beth Israel, and there was a lot of writing in the Boston Globe about how that meant that the Beth Israel was earning too much money. And my reaction to that at the time was, this is a good sign. The fund balance is there for when he needs it to do something important, when Medicare rates get covered. It also means he's not gold plating the offices and building atriums. It means he's saving money for when something important needs to happen. And so, I get worried about these generalizations about the whole sector, about conflating tax exempt status with nonprofit status. In fact, for most nonprofit hospitals, the exempt status doesn't matter that much, except for maybe the property tax exemptions and the bonds. And not letting the nonprofit hospitals keep a fund balance when they're the best situated to decide, a little bit, how they want to budget from year to year.
Maybe that was true of Paul, but I can point to other hospitals that have very nice reserves that do have their offices in the penthouse and are paying their CEOs $8 million a year. And,
and bury their
you
profit.
have big atriums with player pianos and the whole 9 yards.
Right.
So,
and the AG has a lot of tools to take a look at that.
But they don't do it.
But they don't. So, that's not serving the people.
I wouldn't underestimate the degree to which the board members on those well-situated hospitals have tremendous political influence, and where
Yes.
and AGs decide to do other things instead.
Oh, yeah.
Yeah.
So and I don't know if we got your question answered, VIKAS, but there's, we don't have very much time left, but there is one question that I still am interested in, which is one that I believe somebody asked, which is, how do you figure out what right sizing means? So, because only half of the states have certificate, most states had it, 40 years ago, and now only less than half of them have certificate of need programs. These programs are hugely politicized. I know in Maryland, they were very politicized because it was the legislature that was making the decision, and the big hospitals were able to prevent the little hospitals from getting the kinds of facilities like, a cath lab for heart procedures. So how do we figure out what the right size is? Do we have the data we need to know what the right size is? How many beds does any particular area need? How many proton beam therapy machines? How many, cardiac CT scanners do we need?
Well, that's what David does for a living.
Good. Answer the question, David.
Well, I think I'm afraid my co-panelists here are going to accuse me of being Pollyannish and tilting at windmills, but essentially the job that the Health Policy Commission plays in Massachusetts is to try and influence all of these things and do so in an independent way that is not subject to the power and money accusations that have been kind of floated around here about how government actually works. We work on behalf of the people. And I think it has to start with that sense of independence, being data-driven, being evidence-based. And we have a role in really, and have been, I think, very proud of putting very unpopular information into the public sphere that has influenced market behavior in ways that I don't think others would find, predictable. Given the all importance of the market. There is a role for government to play. There is a role for the bully pulpit. And we start from the position of being on the side of consumers, families, and businesses that are paying the very high cost of healthcare in Massachusetts. If we're aligned with their interests and thinking about how the healthcare system needs to evolve and change in order to provide value, Again, Pollyannish, I guess I am, thinking about how Massachusetts was probably Pollyannish and thinking that we could have universal coverage in 2006. But I do think that states have a role to play, and that incrementally we can continue to push and evolve and change. It's not going to be perfect, and there's no perfect payment structure or government system. But I hope that we can continue to think about not just why won't things work, but what things can work and how can we work together to push them forward.
Well, that's starting to sound like closing comments. So maybe we should go there and ask each of us to do that. I got to say, I'll sort of kick it off just briefly by saying, I've learned a lot about hospitals in our development of the Lown Hospitals Index. I knew a fair bit about how this stuff worked when I, was part of a primary care ACO and negotiating with hospitals. But, fundamentally, I think one of the questions that this conversation has raised, and I don't think we've really addressed it, and it's not the time to address it, but is really, to what extent is it even a reasonable assumption that hospitals should be organized through market mechanisms? I mean, there's so many fundamental contradictions in what I think almost everybody who knows about healthcare understands how it works, as well as population health. When you think about this, the optimization of kind of market-driven needs at the hospital level within a system, I just think is a fundamental problem and challenge. And with all due respect to the Health Policy Commission, with all due respect to hospital CEOs, all of us, I think, have to think about this question hard, because there have to be additional tools and solutions that won't be non-political. They have to be political, obviously, but we have to be thinking about those, because I think somewhere in there lie some solutions that we're not yet currently really grappling with. And it feels a little bit like until we do, we will constantly be coming up against this thing. What the COVID pandemic for me feels like is it's opened a door, it's opened a window, whatever the metaphor, to kind of see what could be, and incent us to think hard about things we don't normally even consider as reasonable or feasible or practical or anything, because at the end of the day, until we begin imagining those things, it's unlikely we really will get there. So thank you all. Let's go around. Last thoughts, Paul, and then Jill, Shannon.
Thanks, and thanks to everybody and to the comments we got also.
Yeah.
I think the overwhelming issue that needs attention from both the federal and the state government is that of market power and the perverse effects that market power has on the healthcare system in many localities across the United States. David gave an example of the BI-Leahy merger, where using the authority that was given to them by the legislature, the Health Policy Commission put some conditions on that merger. They did as much as they are legally allowed to do. I would argue that the legislature should have given them more authority, and that the Federal Trade Commission should be looking at these things, and the Justice Department, because I think that's the soft underbelly here that's causing a lot of problems.
Thank you. Jill?
Yeah, I just mainly want to say thank you. This has been really stimulating, and the comments of the participants make me feel hopeful that there's an engaged population out there that's going to make some very needed change. But my wish for this administration is that they can do something about the technical problems that are not talked about, like the ERISA problem that is stopping so many states from making really simple, obvious, helpful changes.
Yeah. Shannon?
I just want to thank all the people in the audience who had such insightful and interesting comments. It was really exciting to sort of be reading that and listening to all of you.
Thanks, everyone. Thanks so much for joining us. To everyone in the audience, big thank you to our guests. Wonderful. Don't forget to visit the Lown Institute Hospitals Index. at lownhospitalsindex.org. And if you have any questions, send us an email at info@lowninstitute.org.